So let's kick off. I'm just gonna spend 2 minutes with some quick introductions, mostly of myself and Yong, and a reminder that this is a discussion for all of us to have about, providing both on how to provide good professional development advice for junior mentees in the field of statistical methods development, but also, and perhaps more importantly, an opportunity for more junior individuals like George to ask their professional development questions. That being said, my name is Marc Suchard. I'm a professor of biostatistics at UCLA. I've been involved with OHDSI since its founding and continue to serve in what capacity I can in kind of its leadership directions. I'm the in name only work group chair for the Legend Group, who has put together a large scale analysis of antihypertensives for individuals newly diagnosed with high blood pressure, and we're continuing our work in diabetes. I also share sort of co-lead-ish type roles with Martijn Schumi in terms of the Hades methods package development and the population level estimation work group. My own professional work is in statistics and statistics for large scale analyses and delivering statistical tools, which hopefully people can adopt to sort of change the practice. I want to take this time to turn it over for a short introduction from Yong Chen, and then we can kick off some development. Yong, please.
Thank you. Yes, my pleasure to co-host with you, Marc. And this is Yong Chen. I'm an associate professor of biostatistics at UPenn. So I got my PhD at Hopkins in 2010, 11 years ago. And I joined OHDSI in 2013. I introduced by Hua Xu, who graduated from Columbia. And then I got connected with Martijn and Jenna and Patrick and Ryan, and we started to work together. So it has been a wonderful experience for me. And OHDSI really motivated lots of interesting problems. And for me, I have been focusing on data integration for real world, specifically for real world data. And our methodology focus on meta-analysis and distributed learning, especially privacy-preserving distributed learning. And we have been actively developing methods and also software and trying to connect integrated software to some existing packages developed by OHDSI, like cohort methods and so on. So that's from me.
That's wonderful. Thank you. Is there anyone that would like to start with a quick introduction of themselves and kind of a question to kick us off?
I can jump in.
Thomas.
I'm Tom White, trained under George many years ago, and I'm now working at MedStar Health in the DC, Maryland area, and we're just starting to implement OMOP there with the goal of using it for both research and operational purposes. And my question is, since we're new on our journey, we don't have a good sense yet of sort of what the boundaries are of what OHDSI can and can't do from a statistical perspective, especially for the operational side of things. So historically, we've got, from a quality and safety, et cetera, perspective, we've got a lot of interventions that we put in place where we want to be able to do program evaluation, whether it's difference in difference, propensity matched, all that sort of stuff. And I've seen within the tutorials, the capabilities that it looks as though it has. But what we're trying to do is come up with a standard approach within our organization so that we can really do this more at scale. And I guess my question is, I don't know the deep details of how to actually run those analyses myself, but I've lined up people at the organization who do. And are there, who would, for someone who has deep statistical knowledge and wants to understand, basically cross-compare what they're used to in terms of doing program design and analysis to what could be facilitated by either OHDSI tools or OMOP in general. What's the best way to sort of line them up with someone who's deep into the weeds and really help them understand the boundaries, both of what it can do now, but also to help influence in case there are opportunities to potentially extend things if there are places where there is broader community interest, but maybe the tooling hasn't been built out yet.
So that's a wonderful question. As sort of trained statisticians, how can we learn about what's available within the OHDSI community, and where its borders might be, as we train ourselves and develop our own careers. What resources within the community have been helpful for some of you?
I'm going to chime in. Harold Lehman, Johns Hopkins, and Yong. I'm sorry I didn't know you when you were here, and Tom. I hope to when we are in person to see you. The fact that you're focusing on operational is something I've been thinking about. Analytic decision support for a long time, and I think OHDSI has that in its thinking. But I do think that there's an issue on how to bring statistical methods to people who are not as sophisticated as you all are, because statisticians don't have time to do that, and they get no reward for helping people, right? You get rewarded for coming up with new methods, but not for spending too much time on helping people. And it goes back when AI and statistics started in the late 80s. It was about expert systems in helping statisticians, and then it quickly went into machine learning. So I do think that part of what and especially for operational, you're exactly the folks who I always thought needed the most decision support. So I just want to make a vote for thinking about providing decision support to analysts the same way we think about clinical practice, just better. Does that make sense?
No, it does. Thank you. Yeah. And I know we've spoken with Paul Nagy.
Nagy.
Okay, sorry. Thank you. Mispronounced it. At Hopkins, would love to sort of connect with you separately, given that we're nearby.
Yep.
Yeah. And then Christoph, you look like you were going to say something too.
Yeah, I was going to say, one way to sort of explore the knowledge that's out there is, of course, there's the various OHDSI tutorials that are there, and there's this new Eden Academy. I haven't availed myself of the ladder, but have been to and watched some of the tutorials. In terms of sort of the user-friendly experience of what people can do, a lot of it's going to be what's been embedded in Atlas in terms of the ability to run comparative effectiveness studies, as well as cohort characterization. That being said, you can pretty much bundle up an R package to run whatever you like across the OHDSI network. So there's sort of this delineation point between what's been kind of incorporated into the standard tools, but you can also, build your own R package, build your own study design that can be run over the OHDSI network as a bundled up R package. So, when I look at what's easy to do and so forth, the, comparing two treatments for their safety or for their effectiveness is one key thing. The other is patient level prediction in terms of machine learning of what happens after some sequence of events, and you can characterize what the performance characteristics are of a model, both in sample as well as across other OMOP databases. And then, of course, earlier than all that is you can characterize cohorts. You can count stuff. You can look at the fraction of a population that has a given condition. Look at different time windows and so forth. Where I run into the limitations personally is in terms of trying to embed my stuff directly into Atlas. There's this big kind of complex web infrastructure, and I wouldn't really know where to start to kind of put my stuff in. So I end up typically running things on top of, pulling data out of the OMOP common data model and running my own tools in R or Python and so forth. But I find, the vocabulary is very useful, and the data models are certainly helpful when I'm working in another domain like recently the Veterans Administration has a very complex table structure, but their OMOP realization of that is, I could quickly get up to speed and do work in that system.
Thank you.
From a professional development point of view, does articulating so we have a lot of guidance and best practices, but they're really pretty high level, and it's like you need to know what you know, and you need to know it, what it all means. Is there from in academic statistics, so I come from an informatics background. I'm a wannabe statistician, and I'm a nut Bayesian, etc. But my understanding is that in academic statistics, you get rewarded for coming up with new methods, and not with creating. Now, you all are, I don't know how, well, not necessarily creating new software or new help and such. Is there value in articulating what goes into the steps of modern analysis at that lower level of granularity, or is that not doable? Is that not helpful? Does it take time away from your real work? Although I think it might be helpful. And personally, Marc, I market the Legend project all the time as a warning to everybody that the way you've been taught statistics is cute and very nice, but it's not the future. But I don't know if and I believe strongly, but I don't think our schools of public health are ready to teach that, and you guys are extended enough as it is. So I might suggest that another part of it is how do you educate people for this new world? Because the old statistics, it's not 1982 anymore. It's not 1922.
Could I comment on sort of the career trajectories that are open? There's this traditional idea that as a biostatistician or informatics person or computer scientist, and my formal training's in computer science, but I've been trained in statistics over the years and picked up the subject matter, there's the small amount of funding that's very competitive to go chase for specifically developing methods. There's a much larger amount of funding for when you can actually answer a biologically relevant problem, medically relevant problem. Traditionally, the statistician or informatician gets themselves split, into all these little 5 and 10% chunks on everybody else's grants, and and then maybe try to get a PI, become a PI on a small methods grant. The approach I've taken is to become a PI on projects that answer biomedically relevant questions. I form a team of the data of the experts in the subject matter, which, you know, I have to have some, but then I have, you know, to talk with them. And it's actually been enormously productive where when the leader of the project is a data science expert versus sort of like, well, trying to get the 5 to 10% of some biostatistician when you're, you know, say an MD in psychiatry and you're trying to do computational psychiatry and you don't have that skill set. So I think by having that skill set, you know, to work with the, you know, the data manipulation and the statistics and pulling in enough subject matter expertise, you can position yourself to do that. And, you know, I actually came out of industry, pivoted, became a professor 7 years ago here at UNM, and managed to assemble a team that's chased some significant, you know, got some significant funds to do large scale comparative effectiveness studies and methods advancement becomes one of those things plugged into the grant. But broadly, you at the end of the day, you have to deliver something, you know, like evidence. And I remember presenting this at a CTSC or CTSA conference where I realized that the dominant paradigm was I'm going to be a 5-10% person on everybody else's grant, and I can't be the leader. And I presented that, well, I've done it, and others have done it in this team, but I think it's often not seen as so much an option. It's I got to go chase NLM money only, or if you're in computer science, NSF, you know, hardcore methods grants versus go deliver on the evidence and bury in there doing some of your methods innovation.
Chris, is that because your projects are in silico? Is that what you're saying? That, or?
Well, my projects in some cases included some work with patients, but largely indeed they have been on, you know, the national claims databases and EHR data and so forth. And we're in an era where that data is becoming more and more available, whether through the N3C initiative, as well as the various, you know, commercial and then local healthcare system databases that are at academic medical centers. And I think there's more and more happening of federation, either centralized or decentralized approaches through OHDSI and the OMOP common data model, where, you know, access to the data is less and less an issue, and then it becomes, where's the data science capacity to make stuff happen? And I struggle with that. I struggle with finding trainees here at UNM, University of New Mexico, to, you know, I got like a year of funding, I could cover a graduate student, but can't find anybody.
My impression has been, for me, that the OHDSI community as kind of an open collaborative has been a good resource to connect statistical methods developers with individuals with domain problems, you know, with domain knowledge. And something that we can do in terms of the development of those individuals is, as Christoph mentioned, the encouragement to look beyond the my role is going to be that, you know, 5% on many different pieces of the pie, and to help the trainees see that they could be the leaders in these types of, you know, leaders, because these are very in silico types of experimentation, as Harold mentioned, right? And now it's been hard to find, I've found it hard to find trainees who kind of, you know, who buy into that. But we are starting to have some success across the community with, you know, some young assistant professors coming out of having done PhD training or postdoctoral training within the community that have that feeling that, you know, their role is to lead experimentation, where experimentation means both experimentation to develop new methods, to, you know, explore ideas, but also experimentation to answer real world questions.
George, I'm going to ask you about informatics training. Now, your program is an outlier, but I don't think that most informatics programs prepare our graduates to deal with this new world, because, you know, they don't get a lot of statistics, and to get to the point of causal reasoning and, you know, massively parallel analyses is after a year or two of statistics, and we don't give them that training. What do you think?
Well, you know, we have a wide range of students who come in. So, you know, I don't think we do a perfect job of preparing people, to be honest, but we have research opportunities where they can go deeply into it over their 5 years as a PhD student or 2 years as a master's student. Our curriculum is set up so that our computational methods course that Noemi El-Haddad created tries to pull them in the data science kind of from this point of view, although it's not really the focus we're talking about now exactly, but it's kind of close. And there's also a research methods course. So we have a series of basically 4 research methods courses: computational methods, symbolic methods,
and a couple of other.
And the fourth one, because there's always that fourth one, which I can't like put my finger on right this second. We try to prepare, you know, as Christoph said, we try to prepare people to go out and lead things and not be, you know, we see our department doesn't follow, like we discourage our junior faculty from being, you know, 5% on other people's grants, or a lot of that. We want them to collaborate. So you have to do some of it because that builds your network. But we want to have them avoid, you know, you should be the PI on each new thing you're doing as a junior faculty member to get them into that quickly. And, you know, as we know, Marc and I are, you know, Marc just submitted to what may be NHLBI or NIDDK or whatever, like trying to submit the grants to actually generate the evidence and not just be supportive of someone else coming up with those grants. And I think that's important for our field. You know, we tend to do it when we're generating evidence that cuts across a lot of areas. Whereas if it's very specific, someone has spent their life on a receptor, well, they're going to write the grant to do that receptor. But if it's something that's cutting across many different like it's all hypertension, but it's many different classes of drugs, you know, having one of us do it still makes sense. How do you embark that on the students? I think, you know, setting example and try to have the courses do it, you know. But, you know, you should realize that our freshmen, our first year PhD students are usually angry at us and complaining because they could go to the Comp Bio PhD and have almost no courses and just start in their research and do research for 5 years. We're torturing them to take all these classes. But what we find is by the 5th year, they're actually thanking us, because when they go for their job interview, the person who spent 5 years on one receptor can talk about that one receptor, and otherwise it's a, you know, quiet conversation. Whereas the person who took our curriculum, suddenly they can talk about biomedical informatics, public health. So they're motivating their work on a receptor based on everything else there is to know about healthcare and biology. So they end up coming back and appreciating it. And we do see some students move from comp bio to clinical informatics, or clinical informatics to comp bio, actually in their 6th, right after they graduate. They move to postdoc and they make a switch, which would seem like a big switch between fields, but for them, it's just, I don't know, I just felt like doing more of that.
So we should make our students take more courses. That's what I want.
Yeah, well, they don't like to hear that. That's for sure.
Yeah, I know.
But you should be efficient of the courses they do take.
So Chen Yu on the screen is one of our Hopkins research master students going to Pittsburgh, and she suffered from our courses and my mentorship. So
Hard to book courses.
I'm sorry?
Only part of the courses.
I see. Okay. The suffering part. The suffering part.
To promote this leadership, at least for most postdocs that come and work in my group, I am strongly encouraging of them to submit, the K21, K23, K00 type awards, which is fairly non-traditional for statisticians. And their success rates at NIAD has been surprisingly high. So we as more established individuals could certainly encourage younger mentees to think out of the box, that I can only go to NSF and DMS. And the idea that they're pulling in these NIH bits of funding helps to sort of cement the idea that a statistician could and should be the leader of leading a research project, and not just filling a service role.
Is there some commonality to the successful K awards, would you say?
Well, it's a self-serving statement. The successful bit has been, I've been encouraging of them.
Okay,
but yeah.
Besides the self-directed, but
yeah,
is there
no.
Is there any structure to the K award that would be?
Yeah, that works. So far, none of these have been OHDSI related. So my career is a little fractured, and I spend a lot of time working on stochastic processes and in molecular genetics. And so they've all been molecular genetics focused. The main structure is they're based around solid methods development with specific applications. Right. So when you start off, our central hypothesis, right? Our central hypothesis is not necessarily the biological question. Our central hypothesis is, tools can be developed to solve this range of problems, and then a fair amount of focus on how those are pertinent biological problems for the funding center. And reviews have not challenged the work on a biological perspective, which is what most of my junior mentees are most concerned about, because that's what they feel the sort of the least confident in.
I wonder how important it is to really have mentors who have successfully competed for NIH funding to really help with these types of K awards. I observe, on the other side of campus, the computer science department here, I have a secondary appointment there, but those folks almost none of them know how to compete for NIH funding. They just narrowly, NSF, and they do have collaborations over here with some folks who compete with NIH for NIH funding, but don't seem to see a way to make that happen. I've received mentorship from those who successfully competed for decades for NIH funding, and I think that made a big difference for me, even as a professor.
I would say that I remember as a PhD student, the idea of needing mentorship was totally alien to me. Right? I assumed, okay, I graduate, I'm done, and especially I was an MD PhD, so I didn't need anybody, and that was foolish. And so if we can get the word to the graduates and the young faculty that they continue to need mentoring even after. And there's no shame in getting mentoring after you graduate. I think that's really an important message. I know. I wish I had seen, I had heard.
Yeah, and I think one of the factors that comes in is while we wish it were perhaps otherwise, one of the main metrics, if not the one we're all at all levels of scale in academia is reputation. So if you think as a lone beginner, you're going to come onto the scene and people are going to give you a bunch of money to do what you want, you know, you kind of need that, you know, you need to have the reputation of those who've gone before you to vouch for you, to be part of your team, and so forth. So, and then, you know, and it takes years to build up that stock of your own reputation till, yeah.
Are you suggesting that your mentor's reputation is your prior and your performance is your data?
Perhaps.
Couldn't resist.
That's why I look towards George to help me out.
I did want to, hi, I'm Zhenya, relatively new. I sit within global medical safety at J&J, so definitely not on the academical side. I did want to bring up a couple of points. One from the perspective of graduate student taking, you know, endless classes and excelling at them. However, what they really lacked is the experience with a large end-to-end project. So we, you know, then go to a real world and we get the dirty data and we have to go back to people we collaborate with to design better experiments. You know, we have to clean this through, we have to create features, we have to aggregate it with some other data, we have to compare across. So all those focused classes and methods never really gave that exposure that the project is messy. There are so many parties involved. You have to take it to completion. You always start with something simple. So really, development of new methods is like the very end of it. Something like neuronal activation and firing, you have to get the video, reduce it, process it, you know, measure certain area in the brain, like all these things. And then modeling of the firing is like a teeny tiny little bit. That's probably 1% of your time. Because when I was doing research and write my thesis, I had a perfect data set that I was just applying, you know, a novel method I think of in the end. To get there is a dirty daily work. And I wish there was like a public health project that we had to suffer through within, you know, 3, 4, 5 years that will give us that perspective. So that was one kind of feedback that I wanted to give to the student on call. And the other thing, since we're talking about OHDSI and AMAP and things like that, I did want to ask, we all know observational data has its drawbacks and issues and biases and, you know, questions that it cannot answer, and or you have to put a lot of inferences about the data to do that, like death isn't measured very well. Are there certain questions that are answered better than the others? Are there certain, you know, population characteristics or things like that, or country characteristics or treatment path that are answered better by this data than like exposure question, for example, to our drugs? Sorry, it was a long question.
Yeah. Well, I think that last part, like there's people here who've given entire talks to answer that question, including George, all the things that you can do and what are the limits of clinical trials versus observational data, and, you know, the looking at data in the real world, longer periods of time, setting up the stage for a clinical trial using observational data, something George has talked about. And so I think it's not either or, it's both and that's a good way to position it.
But if it was a rating, what would be the first thing that's answered the best? Is it prediction? Is it a comparison of the drugs?
Rating in what way?
Like the first thing when you think about observational data, the best question that the question that it answers best would be you know, this? Is there a rating? This is answered well, this is less.
Well, I mean, so yeah, I mean, I think that's what we need to change in the field. But I'll just point out that characterization, just counting things, is a good one because people don't argue with it other than the, you know, measurement error in your database. You can just answer the question. Sometimes it's an important question, and at least you don't have to argue over causality. I think causality is the big one because we're getting better at it and we're getting close to being able to do it and offering not a, first, you know, teaching the field that it's not comparing observational data to randomized trials. It's comparing observational data to expert opinion, because the alternative is not a randomized trial. The alternative is an expert opinion, and that's how most guidelines are written. So that's what you're competing with. And frankly, you know, 10 years ago, you might have gone with expert opinion. Actually, Steve Shea, who I respect very much, is an epidemiologist. He says, you know, randomized trials, number one, physiology, number two, observational research, number three. And that middle one, physiology, is really expert opinion, because it's, you know, it's an assessment based on what the physiology should be doing. And I think we're actually convincing him to swap and change his mind, and that done right, observational data can go ahead of physiology, because it doesn't always work the way we think it will. So I think that's the one. Like, I don't know how to do the rating scale, but that's like, we already know characterization works. This middle one is where I think there's the big switch. Now, there's only so many things we can study. If it's a new drug, we don't have observational data, so obviously it's not very useful there. But there are a lot of questions that we're left with that we do have a track record and we could be learning from it. And then predictions, this exciting new area. We're not doing it, like, we're really screwing up there. Predicting non-causal things that are really confusing people. And it's a fun area, though, and people are getting better at it. There's a couple people, you know, I like David Sontag and Rajesh Ranganath and Mihaela Vandeshar are doing fun things in prediction. So that group, those three groups, kind of working on similar things. We're doing a little bit there. So that's a fun area, but I don't know that we're ready. We're also doing stuff in not OHDSI related, but data assimilation. So using mechanistic models to do predictions. So I think that's an exciting new area, is doing predictions using more biology. So my personal opinion is that, yes, we'll be using observational data, but we'll be incorporating mechanistic models. And that's going to be the big fad 5 to 10 years from now. It's similar to deep learning.
Yeah, and I'm selfishly kind of projecting that on the safety of our drugs. So definitely, I'm sure mechanistic model and, you know, whatever's pathways are linked in the literature would be part of it. Yeah, but also something like how many people and which people are taking the drugs. And we know that Medicare would be very different from some of the commercial insurance data, but yeah, that would be the way to aggregate it. I think that's what I'm sort of having most problem with, because it's oftentimes, well, not necessarily opposite direction that you see in different databases, but definitely disparate results. So that's where if it's more data or broader capture of different groups of population would work. But this is, yeah, you know what I mean.
So let me say, that's what we're trying to teach the field, that when you do multiple databases, we're not expecting them, we're not measuring heterogeneity and throwing it away. When you have a big enough database, your statistical error is irrelevant. And we're trying to uncover the systematic error due to reasonable things, like not just measurement error, but like difference in populations and different times and all kinds of things that go on. And so we do many databases, a distribution of databases, because that's the new statistical error, is the distribution of databases, not the distribution of people within the database. Because it's capturing things that we used to just ignore because our databases were small and our statistical error was large, so you didn't have to worry about that. Now, it really is the difference among these databases that should be telling us the same thing. And like, so why isn't it? And it, we call it systematic error. It's better like systematic variation. Some of it's not error, like it's not a bad thing. It just, we want to understand the sources of variation.
And then as we come, sorry, Harold.
No, I was going to lead to a closure. Go ahead.
Oh,
I just need to drop off.
I was going to say that
Great
now that we solved all the issues, what's left?
No. The only closure comment is I do have to agree that traditional statistics training is certainly lacking that end-to-end approach that is almost required to appreciate the problems. And sort of we as a group can think about how to engage our students in larger projects, but are still kind of doable within the short amount of time that we have. And perhaps OHDSI could help with some sort of externship type of program to give that exposure. I want to be mindful of everyone's time. So thank you very much for coming and contributing. And we'll see most of you throughout the week, but definitely next Tuesday on our community call. Thank you.
Thanks,
George, if you were able to convince Steve of anything, I'm pretty surprised and shocked. If you know Steve, I was his intern.
He's coming.
Oh, he's coming.
Thanks, Bill.
Thanks, everyone.
Good to hear it. Take care, everybody.